Yes, thank you. As I was saying, my name is Kaya Barrett, and I am a nurse clinician in the Cancer Survivorship Program at mHealth Fairview, and I'm joined by Liz Danley. She is my co-host tonight. She is the Survivorship Events Coordinator at Masonic Cancer Center. We are pleased to welcome you to tonight's Thrive series. We just ask you that if you please take a moment to locate the mute button in the comment box. During the presentation, please feel free to use either that chat box to submit your questions, or if you wish, at the end of the presentation, we'll invite you to take yourself off of mute and ask a question. This is the second of our fall 2024 series. We did have a presentation last week on cancer and careers. And one note that we're working to get that recording up available online. So if you're still looking for that, we are working on it. But just want to give a great welcome to you. If you're new to the series, we're happy to have you. And if you're a previous attendee, we are so glad to have you back. Before we get started, I would like to just give a quick housekeeping overview. We are recording tonight's session, so we can post them on our website. We do edit the recordings prior to posting it to ensure privacy. Again, please locate that mute and the chat button. Use the chat during the presentation to submit comments and questions, and Liz and I will be monitoring that. But at the end of the session, you may unmute yourselves and ask questions during the Q&A. And then also, if you are a University of Minnesota employee or spouse participating in the Employee Wellbeing Program, we'll put a link in the chat so that you can complete the survey and mark your attendance to earn those wellbeing points. So with that, let's kick off our week 2 of the Thrive series and welcome Dr. Hordinsky. Dr. Maria Hordinsky is a professor in the Department of Dermatology at the University of Minnesota and the Vice Chair of Research for the Department of Dermatology. She is recognized for her expertise in research in hair diseases and in the peripheral nervous system as it relates to hair follicle biology. Thank you so much, Dr. Hordinsky, for joining us, and we really appreciate your time and willingness to share your expertise with us. Liz will be sharing your slides, so as soon as you can see them up, please let us know when you're ready to advance.
Well, thank you everyone for the opportunity to talk on this subject. It's a very complicated subject as well as a very personal subject and a very interesting subject. So Liz, we can put the slides up. And here they come. So the topic today is on chemotherapy-induced hair loss. What do we know and what can we do? And we can go to the next slide. Liz, we can, oh, there we go. So in this session, we're going to talk about the hair cycle. So there's an understanding of the hair cycle, the spectrum of hair diseases with a focus on chemotherapy-induced scalp hair loss, persistent chemotherapy-induced hair loss, and current strategies that are in place to prevent hair loss as well as regrow hair after treatment. And we can go to the next slide. So in our world, what we hear is that and experience is that hair loss in cancer patients is common and that it is probably underreported in clinical trials. So hair changes attributed to anti-cancer therapies are expected to occur in at least 65% of patients receiving cytotoxic therapies, 15% with targeted therapies, 25% with endocrine therapy, and 100% in areas of the head treated with radiotherapy. Next slide. So hair loss, again, in clinical trials is probably underreported. And in an analysis of phase 2 and phase 3 endocrine therapies in trials, about 94% of the publications did not report hair loss or alopecia as an adverse event. And of those that did report, the incidence of hair loss or alopecia varied widely. For tamoxifen, the range was from 1 to 25%. Next slide. So we understand and know that hair loss can have a profound effect on patients' quality of life. And 50% of patients with breast and GYN cancers who experience hair loss reported that it limited their ability to pursue hobbies or leisure activities or significantly impacted their quality of life. And actually, there's a percentage that would consider rejecting curative cancer therapies if there was going to be an associated alopecia or hair loss with the treatment. Next slide. So in a study of 236 breast cancer patients on an aromatase inhibitor, 8% in this particular publication discontinued therapy because of hair loss. And in another study, 58% of women receiving treatment for breast cancer stated that alopecia or hair loss was one of the most traumatic adverse experiences during their treatment. Next slide. So this is a rotating picture of a biopsy of the scalp of a person who has an inflammatory scalp disease. And this is just showing you the complexity of the skin of the scalp. So the blue outlines a number of inflammatory cells. At the very top, you see the upper layer of the skin, the epidermis. And then you can pick up those structures, those hair follicles in this 3D image that's coming up. And you can see the oil glands or sebaceous glands that are associated with the hair follicle, as well as sweat glands. And I think, there we go. So there's your whole structure. That's what we're talking about. And we can go to the next slide. So when we deal with hair loss, many times we do a biopsy, not always, but many times. And this is a biopsy of the normal scalp. So you can see on its routine histologic picture, those hair follicles go deep down into this section. They're way down in the fat. That's your normal actively growing hair follicle called anagen. And if we go to the next slide, if you do a biopsy and you look at it in cross section, then you're going to see all these what are called follicular units. And you can see that the follicles all look very similar. And again, these are all anagen follicles. In the upper 12 o'clock section, you can see that the follicles are a little bit different. So those are telogen follicles, and about 10% of all the hair follicles on your scalp are in this telogen or loss phase, because the hair follicle is never sedentary. It's always static. It's always doing something. The next slide. So some people, when they receive certain types of chemotherapy, or if they're ill and they have a high fever, or the kind of hair loss that you can experience after the delivery of a baby, the hair follicles go into this telogen phase, and you can see these squiggly follicles here. So this is an example of what you would see under the microscope in someone who's experiencing this very acute transition from the growth phase to the loss phase. Next slide. Well, then the hair follicle actually, produces a hair. So you've got this complicated structure that moves up and down, and then it produces this hair fiber, which can be straight, it can be curly, and you can just click through these slides, Kayla, that would be fine. And just click through and just keep going. And so what people are doing, if you could go back one for a minute. So now what also happens is that people are gifted different quality of hair types. So some people have very curly hair that's very tight, has very tight curls. Other people have very straight hair. And it's very interesting with chemotherapy, sometimes the hair fiber quality changes. So sometimes people who've had straight hair after chemotherapy, they actually come back and they have curly hair. Sometimes it doesn't stay, it goes back to the way it used to be. But it is right now people are unable to predict if the hair quality that comes back will be the same. And we can go to the next slide. And this cartoon just shows you those stages of the hair cycle. So that actively growing phase is called anagen. It's deep down there in the fat. The telogen follicle is the one that transitioned, and people will say their hair is falling out by a root. They'll look at the end of that hair fiber, and there's this little club. That is that telogen club. And then when you start a new hair cycle, you have the hair follicle in early anagen. It's much shorter, and the smaller it is, the finer fiber it produces. Next slide. And this is what happens if you pluck hairs and you look at them under the microscope. There on the left is your telogen fiber. You can see that club, and on the right side, you see this broomstick, and that's that actively growing anagen fibers. If you pluck hairs, this is what you would see. Next slide. So people are graded based on their hair loss with cancer therapies. So grade 1 would be hair loss of less than 50% of normal for that individual. Grade 2 would be greater than 50% normal for that individual. And usually at that time, it's readily apparent to others, and patients will want to buy a scalp prosthesis or wig or hair piece. And many times, and there actually are great places in the Twin Cities where patients can go and work with people who create wigs and actually know how to camouflage hair loss very nicely. And we can go to the next slide. So in chemotherapy-induced alopecia, there's another type of loss that occurs, and that is the loss where the normal actively growing hair follicle, that anagen follicle, is attacked, so to speak, by the chemotherapy, and you have these cells in the hair follicle that are rapidly metabolizing, and what happens, the chemotherapy also attacks those cells, and so you get a very, very fine, immature hair fiber that's produced. And we can go to the next slide. So when you do develop hair loss after chemotherapy, it usually is non-scarring. It means that the hair growth can come back. It's usually patchy or diffuse. It predominantly occurs in like the top of the head and on the sides. And classically, it's thought that the majority of patients will get better within 2 to 6 months after the end of chemotherapy. We can go to the next slide. But then there are people who get persistent chemotherapy, and this is defined as incomplete hair regrowth at 6 months after completion of the cytotoxic chemotherapy. And many times these individuals look like they have female pattern alopecia or hair loss. So there's a strong tendency to have significant thinning on the top of the head with retention of the frontal hairline. And this is most commonly seen in women with breast cancer treated with taxane or cyclophosphamide-based regimens. So in a prospective study of breast cancer patients, 42% of those who received chemo demonstrated persistent chemotherapy-induced alopecia at 3 years. Next slide. So these are just some examples of some of that thinning. So if you walked into a dermatology clinic and did not give a history, this could easily pass for what we call female pattern hair loss, or this looks like an example on the left of male pattern hair loss in a female, or you see on the right the thinning occurring in the temporal region. Next slide. And this would be another example of that kind of patchy hair that's there. So if you didn't know anything about this patient in dermatology clinic, one would be thinking, well, did this person have an autoimmune alopecia areata type process and the hair is coming back? But these are the types of clinical findings that one could see. Next slide. So what about other parts of the body? There could be involvement of the eyebrow region, eyelash region, underarm hair, pubic hair, and recovery there is thought to be more rapid than on the scalp. Sometimes with hair loss and sometimes with hair regrowth, the scalp can have some itch sensation or a pain sensation. And we already talked about how the hair structure can change, and the color can change too. Sometimes the hair comes back darker in color, then goes back to its normal color, or it can become lighter in color. Next slide. So what do people do right now? So in this institution here at the University of Minnesota, we did not do scalp cooling for a while because there's always this concern about, well, if you do that, would you be preventing the chemotherapeutic agent to adequately be presented to the scalp, for example. And so at the same time, other places in the country started to use these more regularly and in very coordinated programs. So much of our data comes from those institutions. So there are static devices like the Penguin device, and then not that long ago, the FDA cleared dynamic scalp cooling systems, which you can use these devices, but you can't use them if there's some hematologic or central nervous system malignancy, cancer of the head and neck, or cold sensitivity and cold triggered diseases. Next slide. So this is an example of that static device, the Penguin device. I don't know if anybody on this Zoom call has ever used any one of these. And then the next slide shows the other one, which is the CoolCap device. And this has fluid running through it that's kept at a certain temperature. It takes practice to really do this efficiently. It also, you have to also then spend more time in the unit as you're getting your chemotherapy. So it adds additional time to the experience. Next slide. So the preventive messages and preventive strategies with cooling are that you're vasoconstricting scalp blood flow. There's reduced availability of the cytotoxic drug to the hair follicle. There's reduced uptake of that medication by the follicle, and there's decreased follicular metabolic activity. So that's what's going on there. And that's why people in some centers, including here, were not that ready to jump on board when these devices first came out. Next slide, please. So the cooling, so what does it really do? So in one study, it was a prospective study of 124 women with breast cancer who received taxane-based chemotherapy. And the scalp cooling conferred protection against hair loss in about 66% of patients, compared to 0% in the uncooled group. And scalp cooling was initiated half an hour prior to each chemotherapy cycle, with the scalp temperature maintained at 3 degrees Celsius throughout chemotherapy, and for about 90 to 120 minutes afterwards. So this is a commitment. All right, next slide. And then the scalp, there's another study showing scalp randomized multi-site placebo-controlled trial of that Paxman device, including 142 participants, 36% of whom received anthracycline-based chemotherapy and 64% received taxane-based chemotherapy. And successful hair preservation was found in about 50% of the women who received cooling. The challenge is that if you look at different institutions, there are really large differences in sites and therapy regimens. So here, we had people come from Ohio State and lecture on this topic of chemotherapy-induced hair loss. They've met with people in the cancer center because there they've developed this very regimented system, in large part because one of the dermatologists there, their clinic is right next door to the breast cancer clinic. And so there's been a lot of teamwork and very easy personal connections to collaborate in an efficient manner. Next slide, please. So the factors that lead to these different scalp site differences, well, the cap may not fit the same on everyone's head. There is this learning curve that improves with repeated use and training, the type of chemotherapy, the dosing schedule, and then just the intrinsic patient characteristics. Hair, you already saw, the hair follicle produces hair that can be thick, it could be thin, it could be curly, it could be straight. And so I don't think these devices have been adequately studied in the right number of people from different ethnicities and those who have different hair fiber diameters. Next slide. So what about adverse effects if you work with these cooling devices? So the most common ones include headache, nausea, dizziness. An analysis of 10 trials that included close to 2,000 patients demonstrated no differences in the incidence of scalp metastases between cooled versus non-cooled patients. And that came out in 2017, leading more sites to become perhaps a little bit more comfortable with this type of, the application of this type of device. Next slide. So what about endocrine therapy-induced alopecia? So many patients with breast cancer are on aromatase inhibitors, and about 34% reported hair loss or hair thinning in the during the treatment process. And these hair changes were independent of previous chemotherapy and age. Because again, as women get older, even as men get older, hair fiber diameter changes, the quality of hair changes. So then if you add on top of that, being treated with an endocrine therapy, like something that's an anti-androgen, for example, then you're going to block the conversion of, or you're going to work on aromatase as an enzyme or something like that. You're going to potentially affect the hair follicle. Next slide. So these are just examples of hair loss in patients who are cancer survivors. And if you look on the right, that type of patient, if they walked into clinic, they would be diagnosed as having female pattern hair loss or female pattern alopecia, which is classically presenting with retention of the frontal hairline, widening of the part width, and decreased density on the top of the head. On the left, you see a very similar, but yet not as extensive process. And there we have to start thinking about different diagnoses. One is called central centrifugal cicatricial alopecia, or CCCA, which is an inflammatory condition that occurs primarily in African women. So when you just look at a person, one has those other items in the differential diagnosis. And then as you go into the history, one will begin to understand a little bit more whether this is more of an immediate type of thinning process or is it persistent. Next slide. So when you look at studies that characterize endocrine therapy-induced alopecia, alopecia was attributed to aromatase inhibitors in about 67% of patients in this study, and to tamoxifen in about 33%. And it was grade 1 that in 96 of those 104 patients. So it's probably like less than 50%. In clinic, we're going to say that once a patient loses about 30% of their hair density, or more than 30%, those around them are going to recognize that there's something going on. The person knows it's happening to them, but those around them may not necessarily recognize that yet. But you saw in that system that was being used, it's more like in the chemotherapy-induced type of hair loss, one is looking at that marker of 50% as being a cutoff between less severe and more severe disease. Next slide. So I talked a little bit about female pattern hair loss. Again, very, very common, occurs in about 80% of Caucasian men, 50% of women will show androgenetic alopecia or pattern baldness by age 70. And there's a strong genetic predisposition that's been implicated, and genetic loci, including aromatase, have been implicated in this condition as well. So we can go to the next slide. So if you have plain old male pattern baldness, or you have plain old female pattern baldness, there are certain tools that we use, and they're very similar to what we use to treat chemotherapy-induced alopecia. So the most common treatment that's out there is to take a look at topical minoxidil or Rogaine. So what do we know about it? We can go to the next slide. So you can go to the store, you can go to Costco, you can go to Walgreens, you can go anywhere, and you can go to the hair area, and you'll see Rogaine there, and you'll see the blue boxes for men and the pink boxes for women. It's the same product. In some cases, when you walk into the store, the pink boxes will cost more than the blue boxes. Sometimes it's the other way around. It just varies when you go into the store. And Rogaine comes as 2% and 5% liquid, and it comes as a 5% foam. It is marketed and approved by the Food and Drug Administration for the treatment of male pattern baldness and also female pattern hair loss, but only the 5% foam and the 2% topical minoxidil liquid are approved in the US for women. But in chemotherapy-induced hair loss, we use these products a lot. So what have people learned? Let's go to the next slide. So in this particular study, they applied topical 2% minoxidil or Rogaine over the entire scalp during and up to 4 months following chemotherapy. And they did a split scalp study. So half was treated with 2% minoxidil and the other half wasn't. And no difference was shown in preventing chemotherapy-induced alopecia. But if you flip it and you look at this other study, in a randomized double-blind placebo-controlled trial, 2% minoxidil application shortened the average length of time to hair growth by 50 days. So once the chemotherapy is done, and the hair is starting and wanting to come back, that's probably a good time to start thinking about something like topical minoxidil or Rogaine. We can go to the next slide. Now, there are other things that you can do. So let's just say we can try to halt the hair loss by using those cold devices. We don't have a lot of data to support using topical minoxidil during the chemotherapy period, but afterwards we have topical minoxidil. And if you're not keen to using topical minoxidil, we have these different light devices that primarily produce red light. And red light, and these devices have been cleared by the FDA, and they actually can promote hair growth. You have to use any of these treatments for at least a minimum of 4 to 6 months before you say yay or nay to these. But these types of devices are commonly used. And we can go to the next slide. And they're working primarily in the red light spectrum, or the red is. So usually they're like 651 nanometers, just to put it into perspective as to where they are on the spectrum. And we can go to the next slide. So there's another treatment that people use once we start talking about oral medications, or what can you do to get your hair back. So spironolactone is a medicine that works as an antihypertensive medication, but it also can block the testosterone receptor on the hair follicle. It's not approved by the FDA, but it's been used for decades to treat that pattern hair loss that we see in regular people and in patients who are getting this chemotherapy endocrine-induced alopecia. So the idea And the thought is that it competitively blocks androgen or these testosterone receptors on the hair follicle. We can go to the next slide. So dermatologists in large part have been hesitant to use spironolactone in women with a breast cancer history. So I think if one goes in this direction, you really have to speak with your oncologist and just make sure that this is an approach that you and the oncologist feel comfortable with. In the third bullet point, it says in a 2020 retrospective study of more than 200,000 breast cancer patients from the Humana Insurance database, there was no increased risk of breast cancer recurrence with spironolactone use. But again, I would come back to having a good discussion with your oncologist. Next slide. All right, so what else do people do? Well, we've had the opportunity to work with some patients who've been treated with taxanes in their chemotherapeutic regimen, who have developed persistent chemotherapy-induced hair loss. They've done all the things we've talked about, like topical minoxidil. They may have tried light treatment. It's just not going anywhere. So then the question becomes, what about platelet-rich plasma, or PRP, which is a cosmetic technique? So that it involves drawing blood from your vein. The blood is spun around in a centrifuge, and as shown in the picture, the red cells go to the bottom, the platelet-rich plasma is in the middle, and the platelet-poor plasma is in the top. And then you can take that area of the platelet-rich plasma, you take it and you inject it into the scalp. And we can go to the next slide. And with that treatment, you can see a mild improvement, but in our experience, it's not enough yet for the patient to feel totally confident that that is worth the investment of their resources and time, because we get excited with any little hair that we see coming in. You know, if we see a mild response, we get excited about that. But from a patient's perspective, I really do want my hair back, not just what you can see with AI technology or with your eye, you see improvement. They want more than that. The new kid on the block is this one. This again would be a aesthetic or cosmetic approach to treating hair thinning and hair loss. This was just approved relatively recently. It is a clear non-ablative fractional laser for improving scalp hair appearance. We can go to the next slide. And you can see on this next slide that if you look at the upper right corner, there are 3 to 6 30-minute sessions a month apart. And when shoots the laser into the skin, it interacts with water, and by doing that produces factors that have been found to induce hair growth. We do not know a lot about how effective this could be in chemotherapy-induced hair loss, whether it's immediate or persistent, but it's another tool that's out there that I'm just bringing to your attention. Next slide. So then we have the scarring hair diseases. I'm just going to talk about these to just show you the spectrum of hair diseases, just so you can be thinking about this, because there are patients who have these conditions, and they come to clinic and we follow them, then they get diagnosed with some type of cancer. In this case, I'm talking about, like in this case, a patient comes to mind as a patient had breast cancer. They go on a chemotherapy regimen and we really think everything's going to get better. And what happens is the cancer goes away, but they come back to clinic and this inflammatory process is still present in the scalp. So this is a little different from chemotherapy-induced hair loss, which the patient still would experience, but we really wanted to see, would there be an effect on the inflammation? And we'll just run through a couple of pictures here so we can go to the next slide. So these are just examples of clinical pictures where inflammation is key to these individuals and to the persistence of their hair problem. And some of the names of these conditions are like lichen planopilaris, that central centrifugal cicatricial or scarring alopecia, frontal fibrosing alopecia, which is relatively new condition, first described in the mid-90s, where the hair follicles disappear, basically scar down, and the hair line just moves backwards. And then something like discoid lupus erythematosus. And the next slide. And then there are these neutrophilic cicatricial alopecias. So I don't think we see these, I know we don't see these as commonly, and we see these more in men than in women. But just something for you to all be aware of, that the spectrum of these conditions is broad. And what we were talking about earlier in terms of chemotherapy-induced immediate or persistent hair loss, really comes down to a non-scarring hair loss condition where these patients, if they come in and they're going to be treated with some type of chemotherapeutic regimen, the effect on their inflammatory condition could be very variable. Next slide. And then there's this condition called alopecia areata, where people lose circles of hair, or they can lose all their hair. And again, this is immune mediated. So sometimes people with alopecia areata get struck with cancer, and now you're going to have two mechanisms, different mechanisms involving that hair follicle. Next slide. So this is the end slide, and then I'd just like to talk about minoxidil a little bit more, but this is a picture of the upper third of the hair follicle in a biopsy. And just to show you how complicated this structure is, in green, you can see the nerves that surround that middle part of the hair follicle. And what that V is, those are the erector pili muscles. So those are the muscles that will contract and cause goosebumps on your skin, because these muscles are present around all hair follicles. And then you have in red the vasculature of the hair follicles. It's a very complicated structure. And I hope I've taken you from talking about the hair cycle, what we see in chemotherapy-induced alopecia, the tools that people are using to really try to prevent the hair loss, as well as try to bring hair back, and the many things that we have available to us. But I'd like to end with just a comment on low-dose oral minoxidil, because that is really the latest thing that most people are doing. So topical minoxidil, and one other thing to remember with this, if you have female or male pattern hair loss and you use topical minoxidil or oral minoxidil, and you get a nice response of good hair regrowth, if you stop, you will go backwards, because that presentation of hair loss is also genetically determined. So the genes will just take over. If you have chemotherapy-induced hair loss, you really don't have a tendency towards hereditary balding, then in theory, you should be able to first try to get as much hair back as you can. And then once you're there, you can try to come off the medicine, because the cause of that hair problem is different from hereditary balding. And when we talk about low-dose oral minoxidil, what we're talking about is a drug that was out on the market a few decades ago, primarily for high blood pressure management. But when it was given to patients, patients became hairy. And someone at the University of Colorado, while doing inpatient rounds, noticed this and put a patent on that particular observation. And then it led through the development of topical minoxidil, or Rogaine. So in the 80s, people did look at minoxidil orally in different hair diseases, but they were using high blood pressure doses, and so patients got hairy, and women retained water and had fluid retention. It just went nowhere. But fast forward to the past couple of years, what has been found is that if you take the lowest dose of minoxidil pill, which is 2.5 milligrams, and you cut it in half, so you're down to 1.25 milligrams, or even a quarter of that, many people will experience a nice regrowth on the scalp. So that is something that's being studied in chemotherapy-induced hair loss, primarily on the East Coast and the New York City area with Dr. Rossi. So people are trying to find the tools that are going to be the safest and most effective in this complex problem that is so psychologically devastating for so many people. So with that, I would like to open this Zoom meeting to questions, and I hope I haven't overloaded you guys with all this information. Thank you for your attention.
Hi, Dr. Hordense. Thank you so much for that presentation. And folks, feel free to drop a question in the chat and/or take yourself off mute if you've got a question. I did want to give a quick reminder that we will be sending a survey link to your email after this presentation tonight, where you'll have the opportunity to give feedback about this program and other programs that you might be interested in. And a reminder that if you do complete that survey, you'll be entered into that drawing to win the swag bag if you are so inclined. So again, one question that came through in the chat, or in the earlier enrollment, was about where patients can find wig support. And you did mention we've got within the Twin Cities area certainly a number of stores, but just kind of comments on that. And then I will put in the chat as well a link to the American Cancer Society, who's a great support for those folks that are living out of the local Twin Cities area.
Yeah, so it's a great question. So last year, probably a year and a half or so ago, it's like, okay, where are patients going to go get their hair pieces and hair prosthetic devices? Like, where do people go? So one Saturday, one of our fellows and I went on a field trip to look at a couple of places. And it's really interesting because you should probably get names from your doctor or for the clinic that you're with, and go explore the places. So there's one place north of Rosedale, which has a very it's a really a beautiful place. It has a lot of different types of prosthetic devices and hair pieces and wigs. You have private rooms there. It's really a very friendly place, a very nice place. So I think if you're working or dealing with, well, any age group, but I was particularly thinking of like young people who really are still also going through a lot of other changes in life. And then we also went out to a place in St. Louis Park where that particular place, I bet many of you already know it, is very focused on working with women who have breast cancer. So they know everybody in these places knows what they're doing. I think it all just comes down to finding the best fit, just like it does with everything else in this area, where you and the person who's working with you is able to offer you what you're looking for that's safe and effective. So that brings us to scalp health. So there are many things out there. So some people get these different devices that are glued on or sewn on to the scalp. So what we see there is, let's say somebody gets something like that and they can only clean their scalp or shampoo it every week or 2 weeks or even every once a month. But then when that thing comes off, one sees a lot of like acne like bumps in a lot of people. There's a lot of scale. And we know that if you disrupt the skin barrier, which you would with acne or a lot of scale on the scalp, that can impact the hair follicle and the product of the hair follicle, the hair fiber. And that's been specifically seen like in psoriasis as an example. I think everyone knows what psoriasis looks like. You get these large scaly plaques. And when they look on the scalp, if you have scalp psoriasis, the type of fiber produced is a thinner, finer one. So keeping a healthy scalp is really part of this whole process as well.
There's been a couple of questions in the chat. I don't know if you are able to see them or if you'd like me to read them.
Yeah, no, I can just read those. Can you talk
Okay,
about the kinds of autoimmune issues that cause hair loss? So there are several. So patients like alopecia areata, the one where you lose patches and you can go and lose all of your scalp hair, all of your body hair, it's an immune attack on the bottom part of the hair follicle. In that other slide with all of those scarring hair diseases, that the immune system is attacking the upper part where the stem cells are of the hair follicle. And then patients who have like systemic lupus, for example, they can experience diffuse hair loss. There are patients who have discoid lupus, where the hair is going to be lost just in the area where the discoid lupus is. So there's a whole spectrum of conditions of autoimmune conditions where one can see the hair thinning or hair loss. And then it says, does this apply to hair loss due to chemo with pancreatic cancer? See, that's a great question, because that example I gave you, that was one of my patients who did have pancreatic cancer and also had that other inflammatory scalp disease called lichen planopilaris, where we really did think that the treatment would have a positive effect on that disease as well, but it didn't. It really depends on what the medications are that you're being given for your type of cancer, because they all have different side effects. So it's a good question to discuss with the oncologist and figure out, what do these drugs do? What kind of drugs are they? What is the data on hair loss? And also, the impact, to discuss the impact of hair loss on you as a patient. And then there's a question, my dermatologist suggested taking men's Rogaine for my breast cancer hair loss. Is it safe to use hair coloring with Rogaine, or is that too many chemicals for my hair or scalp? So that's another great question. In this day and age, it is amazing to me what people purchase off the internet or from TikTok, or for just social media, because so many different shampoos and conditioners And that brings me to one other point here. It's been interesting for us to see where, like with the light, you know, I was showing you those different devices, those red light devices. All of a sudden, they started to work with patients who had had cancer, and all of a sudden, they were selling a particular shampoo and conditioner to that cancer patient. And it's like, okay, we have to think about products, chemicals, and sensitivity. So if you're using a product and it irritates your skin, don't use it because it's only going to make things worse. If you're looking at products and the ingredient list, like today we had a patient in the clinic this afternoon who really likes a certain shampoo, and we asked, well, what are the chemicals in there? And there was about 20 single spaced lines of chemicals. Do you really need that? If it doesn't cause irritation, you're probably okay to use it. The men's Rogaine, it comes again as a liquid and as a foam. So sometimes if you put the Rogaine on your skin and then you do something else like hair coloring and you do it like too close to each other, you could get some irritation, but in theory, you should be just fine. The Rogaine application, the bottle will say 1 milliliter twice a day for men, and it'll say 1 milliliter or 1 application daily for women. And again, this comes from the FDA clinical trials. So that's how you apply it. But is it, in terms of that question, is it safe to use hair coloring? The answer should be yes, you should be able to do that, but it comes down to common sense. If a product or chemical gets on your skin, irritates it, don't use it. That would be the best answer. And then the next one is, how long post-treatment can hair loss treatment be initiated? So that one's also an interesting question, because let's say someone had chemotherapy and it affected that growing follicle, that anagen follicle. So the hair is still in the follicle, but the fiber that's coming out of it is not as healthy as it was previously. So now the chemotherapy stops. That person should theoretically recover very, very nicely without a lot of additional treatment. If the recovery is slow, then that's the person who could add red light, they could add minoxidil topically or orally if approved or okay with their oncologist. So it depends answer depending on what the person looks like after chemotherapy is finished. The problem area will be those who develop prolonged chemotherapy-induced hair loss, and when they come to clinic to seek treatment or therapy, because probably the longer that follicle stays miniaturized and smaller, the harder it is to get it to become more normal and produce a very normal hair fiber. So I would suggest that once chemotherapy is finished, if there's evidence of regrowth and everything's going in the right direction, you probably don't have to do anything more. But if there is a delay, then that would be a good time to touch bases with someone to discuss treatment options. And then there's another one.
Yeah, I was gonna say there was one earlier up to about if minoxidil affects hormones, specifically estrogen, if a patient has hormone positive breast cancer. Are there any contraindications there that you may know of?
Yeah, so I would say in large part that minoxidil is believed not to affect the estrogen pathway. There isn't a lot of data to support that. If you look in the literature, you're going to find an article or two that does talk about that, but its mechanism of action is on an enzyme in the hair follicle, and it does not necessarily impact the estrogen pathway. Like if you were going to be prescribed finasteride, for example, to block testosterone production, the production of testosterone to dihydrotestosterone, that definitely has an impact, because you block on one end of the pathway and you shove it or push it towards the estrogen pathway. So that you definitely should stay away from. That's where the spironolactone comes into play too, where there's the opportunity to target the testosterone receptor. But 95% of the time, most people are going to tell you that minoxidil does not have an effect on hormones. And then there's one here, it says, who would we talk to about what treatments may be best for us post-chemotherapy? I would probably, this is just me speaking, I'd probably start with your oncologist, because the oncologist will probably have a relationship with a dermatologist. And if they don't have that kind of relationship, then the thing to do would be to reach out to a dermatologist or even your primary care doctor to just get things off the ground and get that evaluation done and figure out what the best pathway would be for the next several months or years. And then what was it we were supposed to stay away from if you are estrogen positive? Anything that blocks the conversion of testosterone to dihydrotestosterone, like finasteride does or dutasteride, you want to stay away from that. And then the question becomes, do you have to stay away from spironolactone? There's that one large article that said it was okay to use in patients who had a history of estrogen positive breast cancer. But in my mind, I would strongly recommend that the discussion be between you and your oncologist. And my guess is people are going to be pretty conservative and probably say to wait and use other tools. And that's where those other tools come into play, like minoxidil topically, platelet-rich plasma, the laser, or red light. So you have lots of different things that can be tried. Kayla, are there any other questions, comments?
I think one fell away. But if you, I thought I saw it pop up. What is the experience like for folks that have multiple rounds of chemotherapy? So if they've had recurrences and then have new treatment, would they experience a more prolonged or more severe hair loss as rounds of chemotherapy or exposures to chemotherapy pile up?
I think that one would all depend on what the chemotherapeutic agents are. So so if you have multiple hits with agents where the hair follicle can recover quickly, then you're probably going to bounce back quickly. But if it's multiple treatments with a group of chemotherapeutic agents that are already known to have a negative effect on the hair follicle, then it might be harder.
Mm-hmm. I think just my last own personal question is, what makes you excited about the future for chemotherapy-induced hair loss? You spoke about some of the light therapy options and et cetera, but is there other new things on the horizon that you're hopeful about, or things that are coming out of research?
Well, I have to say that probably one of the two things. One is the number of tools that are going to become available or in the process of becoming available or even are available haven't really all been tested very well in chemotherapy-induced hair loss. So there's plenty of opportunity to do this in a very systematic and synchronized way to benefit patients. The other thing is that the person at Ohio State who works very closely with their breast cancer unit, we've developed a relationship that is kind of like a mentor-mentee relationship, but it works both ways. So we learn from them at Ohio State what they're doing and putting papers together and publishing. And so even when you say red light, oh, hey, there's red light available, here are all these different devices. When you really look in the literature for what is effective, there's not a lot out there. So there's one device made by a company called Revvion, which is a helmet. And so they now have started a very systematic clinical research trial, like the kind that needs to be done with the group at Ohio State. And so we partner together in terms of like students and residents crisscrossing between the two institutions. But it's going to take a lot more coordinated effort to really come up with good solutions, or like the platelet-rich plasma part that we talked about earlier. Those platelets produce a lot of growth factors. And we got the approval from oncology to go ahead and use the particular patient's own growth factors to see if there would be an effect on the hair follicle. And what one needs to figure out is, if you have an effect, which are the good growth factors? So that's another area where really looking at platelets, growth factors, all that sort of thing, there's a lot of opportunity. But I also think for everybody on here, I'm not sure, what your personal situation is or what you have experienced, but I think when you write your comments, it would be great to hear from you, because I don't think this is a topic that is discussed here on a regular basis. Kayla, I'm not sure if you would agree with me on that.
Yeah, this is our first time covering it, and we know how impactful it is, both from a psychologic perspective as well as a cosmetic, there's so many impacts related to chemotherapy, hair loss. So yes, that's why we're so grateful to have you talking with us tonight.
Yeah, and I just think, the more we could, here's another thing you should all be aware of. So there's also a relationship that's developing with Mayo Clinic. And the university, the state has this program where you can do research projects with the two institutions. So we did put one in on chemotherapy-induced hair loss, and it kind of made the first cut. We're still like moving forwards in that, but it's really to look at, again, a different form of drug delivery to the scalp to really hone in on what's going on in the skin. And the people that we really would love to study at both places, and remember, we're at least a year away from starting all this, but would be the patient who has permanent chemotherapy-induced hair loss, because that is really one of the most difficult situations to really be able to be successful with.
Great, thank you so much. There is one last question that snuck in from Lynn here. Are any of the aromatase inhibitors less likely to add?
Yeah, no, that's a great one. As the technology changes and the aromatase inhibitors become better, perhaps. I think what we've seen in clinic, I don't know if we have enough experience yet, but we definitely see in clinic that pattern of baldness, like you see in female pattern baldness. Now, with the different aromatase inhibitors out there, and also the duration of how long people have to be treated, I don't think we have a lot of good, solid long-term data. It's very individualized. Oh, you're an aromatase inhibitor. You have pattern hair loss that's developed. Here's what we're going to do about it. But I don't think we have the data to say with X we see this, and if we do Y we see that. So lots of work left to do here.
All right, everyone, thank you so very much for your questions. And as Dr. Hordynski suggested, please add some additional comments into the survey this evening if you've got additional thoughts or questions about it. We are going to put the chat in the link if you're interested in registering for subsequent sessions and you've not already done so. We again want to say a very huge thank you to Dr. Hordynski tonight for joining us, sharing her time and her expertise. Really a very fantastic and information-filled presentation. So thank you so much for your time tonight.
Well, thank you again for the opportunity to talk on this topic, but I did see one more question come in. It's
yes.
one. Any chance these therapies will be covered by insurance? The light devices, you probably have to pay on your own. The PRP treatments, the laser treatments are all considered aesthetic procedures. But when we start talking about low dose oral minoxidil and prescribing it in clinic, then it becomes part of a clinic evaluation. And in large part, we haven't seen any issues. The topical minoxidil or Rogaine, you do have to buy on your own.
Great question. And then just a reminder, next week's session is going to be on Wednesday night, October 23rd, instead of Tuesday. We will have Dr. Kate Shafto talking about eating to support healing, and she will be presenting from her kitchen and cooking along while we talk. So thank you all so very much. Have a great evening. Thank you again, Dr. Hordynski. We appreciate it.
Thank you, Liz.
Yes, take care, all. Have a good evening.